the courses, we have the required training, but how do you act when you actually confront with a very sick or talk or die patient or a very, uh, patient with a right hand? So first of all, we need to have a solid training base. If we are working in emergency, we need to have all our life support courses like ATLS, ACLS, BLS, TALS, whatever. So we need to have a solid training base. If you don't have that, then it will be difficult to, care for the sick patient. Now, what is this full stomach and empty bladder? Whenever you come to your shift, you should be full stomach and empty bladder because emergency is anything, anytime, anyone. So you should be prepared. Now, how can we do that? 0 point survey. Wherever you're working, the big or small, do your joint this 0 point survey. This is very important so that you are prepared. 0 point survey can be summed up with step up. S is for the self, like the pilot. You are physically, mentally, or spiritually, you are okay, you are not sick yourself, so that you can take care of your patient. And then your team members, you need to interact with your team member that they are on the same platform. Like somebody is not angry, maybe he had a fight with, I want to say wife or girlfriend. Usually people don't fight with girlfriend, usually it has to be wife. So like they are also at the same the same plane as you are. So they are also ready, pumped up. They are also research ready. And then close loop communication. I will consume 5 minutes of the next speaker. I am sorry for that because it's slightly long this presentation. So we have to follow close loop communication. And then S, the T is T, E is the environment. How's your environment? Like if it is too cold, switch on the heater. If it is too hot, switch on the conditioner. So we have to have a comfortable working environment, which is unfortunately not there in India. Our patient just drops in. That's why we need to have more, chances that we should have an emergency mindset. And P is our priority. What are the priority of our patients, which can be life-threatening, and in order we have to take care of that. So all these if we do, then we are research ready. The important thing in emergency that we have to be research ready all the time. We have to keep mental visualizing that such patient with the bleed, with the polytrauma, with the cardiac arrest, with some poisoning is coming to us. He's visualizing all the times, like when you are in the shift. And this is a new concept, like cognitive aid. Like if you are not very sure, like when you are resuscitating a cardiac arrest, but you are not very sure what are the 5H or 5T, then somebody, one of your team member can go online and can find out what the 5H and 5T. It doesn't mean like if you don't know that you don't look online. So this is like whenever you have confusion, like how much calcium is to be given, if you are following massive transfer protocol, please go online and find from the right sources what are the doses rather than messing up. So make use of cognitive aid whenever you are working in team. Now, I just whenever we confront sick patient, so are we threatened or we are challenged? Threatened means like we start having fight or flight or freeze reaction. Or challenge means like okay, I have been treating such patient, I'll take care of it. This is one of the challenge. So you have something like self. You please play the video. Now this is the patient who actually now see the staff is running helter skelter because they are feeling threatened. What is going to happen? This is my hospital only, but for gunshot if it is in the chest. Put your scan probe on the heart, see the heart activity, whether it is contracting or not, whether the cardiac component, and go accordingly. But so they are feeling threatened because they don't have that kind of drill, they don't have simulation, right? But still, you will just see the patient shot in the abdomen, chest, and there is the blood. There is the blood. How can we avoid being threatened by deliberate simulation practices? That's what we need to do in India, and we need to do for not so sick patients. One can take care of. But I'm talking. All my cases will be patient life of the life, patient having life threat. Okay, so we need to have challenge kind of system, and now you can beat this stressful. So just the first letter of the B is do some kind of breathing exercise. Either it could be triangular breathing, it could be like, but the essence is your expiration has to be longer than your inspiration. Then only the vagus nerve is stimulated, and what we want our parasympathetic system to be active or at par with our sympathetic system, because such patient come, my heart rate is more than the patient's heart rate. I feel threatened. There is nothing. First take your own pulse. Then you feel what is the patient like. Okay. And the B is breathing. T is positive self-talk, like with the team member. Okay, this patient has come. We will take care of it. We have been taking care of such patient. So have a self-positive talk. And S is C. Mentally visualize. Like if this will come, so I'll talk a little bit later in the bottom. So keep visualizing what kind of patient we are going to have, and the full F, focus. So like if there is a patient with certain airway, everybody should focus on the airway. It is not like they were not situationally aware what is there inside the water, and secondly there was no plan B for that. So they just entered into the pond and they died. Similarly, in emergency, we must be situationally aware. It is not like first you do the eyeballing. Is patient sick or very sick? Very sick, how quickly he can die? In minutes or hours? So because I will be I'm talking about the very sick patient. So this situation is very, very important. Now please play the video. You just look at this first slide. The saturation is going 71 and he is not bothered. The surgery is going on and suddenly pericardic arrest. So we have to be situationally aware what is going on, what has happened and what might happen. So this happened and we have consent for all these. You don't repeat just once only.
कौन सी दूँ
So situation awareness is very, very important.
रोटेट हो रही है क्या
उसी में वीडियो में
66. Tachycardia is also made. Second one. Now this is a patient. This is not a pain. This is a patient of road crash. Now we are trying to sedate him. So what is your situational awareness? Somebody, if we sedate someone, what will be our proactive approach or situational awareness? We have to take care of his airway because we know he is going to relax and he is going to fall. Somebody there at the head side now. Next one. So already he is doing a job first, and we are oxygen like ready to go. So this is situational awareness. Next one. Now this patient came to me and he was having a chest open wound, heart was visible, lungs were visible. Now one of the nurses said that please call sir, because now they could understand this is beyond their capacity. So they are situationally aware that they will not be able to manage this patient. So and finally this patient was very sick, so I took him to Vedanta, there I am. So when your capability exceeds patient needs, you transfer, and then we brought him back and ultimately he survived. The middle one. So situational awareness, not only with the team, not only the leader, but everyone. Sometimes you have to bring the other person in the situation because they get distracted. They start cross talk. So this is very important, situational awareness. Next.
नेक्स्ट
Now, what is your plan B? We must have a plan B. First video, please. Now, this is Mrs. Elon in 2009 in UK, and she went to hospital just for a routine nasal surgery. The anesthetized her, and then they were not able to put ET tube. They were not able to intubate her. So one after the other, doctors came. They got fixated. Fixation is another problem we should be very careful about. Fixation. So one after the another, senior consultant came, they tried, they could not intubate, and one of the nurses rather alerted them, don't trust me, but like ego problem, hierarchy problem. So they could not do anything, and next day, patient died. Now her husband was a pilot, he is Martin Bromley, and now he is teaching human factors to doctors. And in India, we are not talking human factors even today. We are not talking, we are just teaching skills, no human factor we are teaching. Anywhere, I have not seen the research. Okay, the slide. So this patient came to me around 2 a.m. This was my first try I did. So in full of blood, severe maxillofacial injury. You will see this is the LMA, but we are not getting the right stat. So this
Maybe
LMA stat will be full of blood. But I have to do, otherwise I have lost the patient. So I basically, one advantage I have that I keep demonstrating all the procedure on my mannequin, so I have become some sort of expertise. I do deliberate practices. You must have heard 10,000 hours of deliberate practices of Anderson, right? And luckily, this patient was saved. So this is the magic will come with deliberate simulation. It's not like you go ahead and cut the neck. It's not like that. First you should do deliberate practices multiple times. And this is a hero procedure. Like you should keep this mini, I have designed a mini drive trainer. In office also, you can just do once in 3 months, 6 months. This is how Western experts do their stuff. So we need to replicate that if we are dealing with high stake scenario, because I do have very sick patient in trauma. Next, please.
नेक्स्ट नेक्स्ट हो जाएगा फिर
No, the same. So that this is the patient who survived,
क्या करें
and this is the cognitive bias. We have cognitive bias. Somebody is after road crash like he is drunk, right? Patient of trauma, whether he is conscious, he is talking, there is no pain, still we apply cervical collar. Okay, so we should be avoiding cognitive biases. Now, what is flexible intuitive thinking? Now, there is the agitated patient. We get now, they're drunk, they eat chicken, especially on Friday and Saturday, all the people. Sometimes I do, but I don't try that. Then, agitated patient, he has a threatened airway. We need to decompress his abdomen. Intubate. So, hold yourself. Don't start doing things which are not needed in that time. Now, important aspect is what if your algorithm failed? What if your ACLS algorithm failed? And he flew from New York, and after 3 minutes into the flight, both the engines they were damaged by Canadian geese, and there is nothing he could do. Either he could go back or forward, and it was over the New York. So what he tried every algorithm. We get algorithm from the aviation industry only, and their algorithm fails. What he does intuitively, he lands the plane on the Hudson River, and all the passenger, all 154 passengers were saved. So this is how, like, when algorithm fail, what will you do? And in emergency, most of the time, I mean, Indian, because there's no EMS, they will just drop in. Our algorithm fails very frequently, right? So we must take a clue from, you must listen to his talk, Solin Salenberg. Very, like, very impressive, very, knowledgeable. You learn a lot of things from him. And then, of course, flexible thinking. This was, I was designing IO, and then one patient came, she was bleeding, malaria, collapse, and then the bleeding. That was my initial stage of the power driver, but we have neither. We have ETO also. So we used to keep one ready, and we did the IO, and she was saved. Now, don't give opportunity for unnecessary failure. What is that? Like, don't try to intubate a patient with full stomach. What will happen? He will vomit, choke on his own vomitus. So don't try to give opportunity for unnecessary failure. Like there's a patient bedridden, leg are swollen, you do scan, there's a DVT. Don't wait pulmonary embolism to happen. Take action. And similarly, when you're intubating, your first try has to be the best try. It is not like, Abhi, let's do it. Oh, does it happen? Now bring this, bring that, everybody ready? This happened. Let's, our first try should be the best try. Okay. So must not give opportunity for unnecessary failure. Now play this video. If something goes wrong with the patient, anesthetic is doing something, surgeon has gone inside the corner. There is no teamwork. Surgeon usually go away from the patient rather than helping out, finding out what is the problem. Can I contribute? He is in the corner. That happens. Where is the teamwork? So we need to have teamwork also. Even if it is our not field. Chest of what is pre-mortem? This is the concept by Gary Clay. Suppose a trauma patient comes. So what are the injury one can suffer in chest trauma? Anybody? Like lungs, heart, esophagus, aorta, pneumothorax, multiple rib fracture. We are talking about the lethal injuries, right? So you pre-mortem, you think like pneumothorax, cardiac tamponade, dissection, maybe traumatic aortic injury, and patient dies. Next time, if similar patient come, then you have all those injuries in your mind. Like you rule out everything from pneumothorax to cardiac tamponade to traumatic dissection of the aorta, everything. So this is pre-mortem. You need to have this pre-mortem exercise in your mind most of the time when you are duty. Because emergency again, our emergency is far complicated than the America or US West because they just drop in. Okay, he was lying on the road. Now I have brought to you. Now do whatever you. There is no history. There is no information. There is no attendant, and you have to manage. So pre-mortem, like keep visualizing. One patient will come drunk in the night. Police will bring, and he will be having no mobile, no purse, no address, and then you struggle with him. Okay, that's real. I mean, we should be having India-centric thinking, right? That dealing with uncertainty. So this is a patient traumatic cardiac arrest. This is a robot. Please play the video. I anticipated that one day I will get a patient for traumatic cardiac arrest. That is why I got a rib spreader, this velociter retractor. So we started blood from both sides. I did a ultrasound and then I exposed his heart. So for medical, this is not disturbing. So we don't have to say okay, this disturbing or sensitive content. This is for our learning because this research promote is being done or being done in India, and we have a fantastic trainer. That is why, despite being happening from internal medicine, I could perform this procedure. So that again, then you become more confident when you do deliberate practices. So then you do whatever in your capacity. Patient injury itself is that patient doesn't survive. Don't suffer from imposter syndrome. Like, why should I become a doctor in the first place? I am not the right person to be in the hospital. Don't start doubting your abilities. Patient with unsurvivable injury don't suffer from what we call the imposter syndrome. Right? Don't do that. I mean, you have treated so many patients. If one patient dies, and that is like traumatic cardiac arrest, then it's okay. You have given your best chance. Your intention has to be honored. Then never waste suffering of your patient. Learn from their suffering. Now again, this is a patient, traumatic cardiac arrest, in the video. So what I'm doing, finger thromboscopy. So we have to perform bilateral finger thromboscopy. So that's what I'm saying, research ready. We have all these things ready. Patient comes, blood, ultrasound, and usually they land up around 1 o'clock, 2 o'clock in the night. So I have just done the finger thromboscopy. Can you see the IO in the leg? So such patient who come collapsed, the IO is going on because with IO you have to use pressure infusion bag. You just do finger thromboscopy. Now I am going on the other side. So you can put more than one IO also because I mean force her that she will have a prolonged resuscitation. So this is on the other side. Now, how can you learn from the suffering of your patient? Finding your blind spots. Where is my blind spot? Here. I can't see. I can see your blind spot. Okay. So you can discuss with your team member, but our team members are not very forthcoming. They will not say anything because of hierarchy gradient. So this is the human factor. We need to bring that hierarchy gradient down. So like in USA. We talk about USA, but it will take long time. I don't know whether I will be alive or not to see that kind of stuff. So, must not waste suffering or patient. That's it. And now, in 2 seconds, give me the answer. 2 seconds. 2 seconds, and we will give special gift. Ball, what ball cost? Anyone? Time is over. कोई तो बोलो.
5 paisa.
That's one answer. Anyone? 10 paisa. 20. Yes. This is just fun exercise because you were sleeping, so I thought let me stimulate your brain. भाई ₹1 का बैट है और बॉल कितने की है? अभी दोनों चीज ₹1.10 का है. बैट इज ₹1 कॉस्टली देन द बॉल. तो बैट कितने का हो गया? ₹1.10 का. और बॉल 10 पैसे की है. तो दोनों कितने के हो गए? ₹1.20 के. और इधर तो ₹1.10 ही है. So this is system one thinking. I'm trying to find out. We have two systems, system 1 and system 2. System 1 is involvement. ये 10 पैसा. System number 5 paisa. The answer is 5 paisa. So we need to train our system 1 in system 2 fashion. System 2 is logical. It reasons out the things. System 1 is involuntary. Like somebody jumps on you with the bike, you immediately. No thinking, nothing, no interpretation, then you think. So this is primarily our primitive thinking, type 1. It helps us in our survival. Our cavemen, they could survive because of this system 1 thinking. They saw the tiger, they ran away. Or they fought if they were in groups. So system 1 thinking is good. Sometimes it's good, like you see the patient, you do the intervention, it's fine. But what is known as heuristic. But most of the time, it will not work. We have to have a system 2 thinking, like reasoning out. Of course, I say whenever sick patient come, double your thought process, double your body language. So that was it, 5 paisa, and that's it. Thank you very much for your attention. Any questions?